Hello, ladies and gentlemen. A very warm welcome and good afternoon to all of you. Well, it gives me great pleasure to welcome you to the Facebook Live session on cancer during pregnancy, organized by Mount Alvernia Hospital and Icon Cancer Center. Thank you so much for joining us. Well, my name is Catherine and I am your host this afternoon. Well, we are very privileged to have with us today two esteemed speakers to share more insights about the topic. So let's welcome Dr. Guek and Dr. Timothy Lim to join us here on the live session. Well, having cancer during pregnancy is rare. It is estimated that 1 in every 1,000 pregnant women is diagnosed with cancer. Breast cancer, melanoma, cervical cancer, lymphoma, and acute leukemia are the most common diagnosed cancers during pregnancy. Well, because it is rare, not a lot of information may be available, and making the right decisions for treatment can be challenging. Management of patients with cancer is particularly the delicate affair. Well, we hope that you will be able to understand the risks and know what are the treatment and surgical options available from our session today. Our first speaker is Dr. Guek, medical oncologist from Icon Cancer Center. Prior to joining ICON, she was trained at the Dana Farber Cancer Institute and also practiced at the National Cancer Center, Singapore. Well, Dr. Lee has a strong focus on research and has been involved in a number of Singapore studies, including identifying the barriers of trial participation amongst Asian populations and young women with breast cancer. Well, she was involved in setting up the Young Women Cancer Program in Icon Cancer Center, for which she is currently the program director. Her subspecialty interests are in breast cancer, young women with breast cancer, pregnancy associated breast cancer. And today, Dr. Lee will be sharing with us on the topic of breast cancer and management during pregnancy. So, shall we please welcome Dr. Lee?
Thank you, everyone. Thank you for joining us, taking a precious time and joining us on this Saturday afternoon. So without further ado, let me just try and share my screen first. Okay. So I know our topic today is on cancer during pregnancy. However, I think to start off by talking about breast cancer during pregnancy, it is very important to have a holistic view of breast cancer on the whole. So I'm going to just start on the basic first and then move on to management during pregnancy. Thank you, Catherine, for the lovely introduction. Basically, my specialty, I'm a medical oncologist, and my specialty is mainly on breast cancer amongst general oncology, and my interest is also in breast cancer as well as gynae cancer, mainly female cancer. So I work with a lot of patients, especially young women with breast cancer, as well as pregnancy-associated breast cancer patients. So the scope today I'm going to share will touch on the burden of breast cancer, some symptoms, risk factors that all women should be aware of, and also I will talk about breast cancer in young women and also a case study to illustrate that. I will touch very briefly on fertility preservation and also management of breast cancer during pregnancy. So I think all of us are not unfamiliar with this graph. It really depicts the top 10 most common cancer in Singapore amongst female. So if we look at the pink line, it really depicts the rise and the incidence rate of breast cancer. And we can see that it's really rising quite rapidly. If we compare like the 70s to the current period, we see almost a tripling of the breast cancer incidence rate. However, if we look at the two graphs, the first one on top is actually the incidence rate. We can see that it's rather steep and rising, but we can also see that the mortality rate, which is the graph below, it is actually fairly stable. And that is good news because what we are seeing is that breast cancer screening is really helping to pick up early disease, which can then be cured. When we talk about breast cancer, we are just talking about, cancers that arise from the anterior part of the breast, but where exactly did it come from? I think it will be clearer if we look at this pictorial representation. And if we look at the picture on the right, we can see that the breast tissue is really made up of like tissues like fats, muscles, connective tissues. But the structures that really give rise to cancer is the ducts that communicates between the lobules that makes the milk to the outer part of the skin. So the ducts carries the milk, and the lobules are structure which produces the milk. So breast cancer really commonly arises from the ducts, which we term them invasive ductal carcinoma, as well as from the lobules, which we term invasive lobular carcinoma. So generally, these are the two most common cancer that arises from the breast. What are some of the common symptoms? So we usually see like breast cancer patients presenting with a breast lump, and that is going to be the most common symptom. However, it can also present as a lump in the armpit or even, changes in the shape or symmetry of the breast. It can also present as skin irritation or nipple retraction or frank nipple discharges or bleeding or even pain. However, I do want to assure most women that, these symptoms can happen even if you have benign breast-associated disease. So if you find any of these symptoms, please do not panic. It's very important to seek medical advice, make an arrangement to see your oncologist and get it sorted out. So I really want to empower women, with regards to how we can more actively protect ourselves. And that will help if we understand and know the risk factors which are associated with breast cancers. Generally, we want to dichotomize the risk factors into modifiable risk factors and non-modifiable risk factors. So the modifiable risk factors are the changes, are those that we can do something to change, while the non-modifiable ones are those that we can't do anything about. So what are the examples of modifiable risk factors? So some of the examples include sedentary lifestyle, obesity, alcohol consumption, smoking, and also taking hormones in the form of hormone replacement therapy or certain type of oral contraceptive pills. Some of the non-modifiable risk factors will include like being female and aging, things that we can't control, and also certain races, and also some family history, especially those with a strong family history, or even frankly, BRCA1 or 2 positive. Also, some other factors include like early start of menstruation, late menopause, or delayed or no childbearing, because it essentially exposes our female body to more female hormone throughout the whole lifetime. And also for some patients, especially when they are young, they may have certain childhood diseases that requires them to have chest radiation. And this can then predispose and increases their risk when they are adulthood. So what can we really do? We can exercise, we can try not to drink or at least drink in moderation. We can try to quit smoking and also try to keep a healthy weight. So by WHO criteria, we should exercise at least 150 minutes a week, and that we are talking about moderate intensity aerobic activity. Also, this should be coupled with twice a week of muscle strengthening exercise. So, when we talk about 150 minutes a week, if we divide it into 5, it's 30 minutes a week, 30 minutes a day for 5 days a week. And that's not easy. So even for me, I find that to be very challenging. So what I really advocate is to do something you really enjoy with people whom you enjoy the company of. So we can see this is a lovely scenery and a lovely picture of my Mont Blanc trip, where it's really a path, a hiking track that goes around Italy, Switzerland, and France. And you see all the happy faces, and that really is the consequence of exercise-induced euphoria. So my best advice is to do something you really enjoy with people whom you enjoy hanging out with. So, American Institute for Cancer Research has all these cancer prevention recommendations. They are essentially things which we have highlighted just now, but in detail, basically limiting consumption of red and processed meat, limiting consumption of fast food and other processed food high in fat, starches, or sugars, and basically eating more of whole grain vegetable, fruits, and beans. Of course, be physically healthy, active, and keep a healthy weight. And especially for women or for patients who are cancer survivor, then you need to follow a cancer surveillance protocol, and that you have to check with your oncologist. So for breast cancer screening in Singapore, we do have a screening guidelines. For women above 50 years of age, you're advised to go for mammogram once every 2 years. And if you're between 40 to 49 years, you're advised to go for mammogram screening once a year. So especially for women with a significant family history or even personal history, you are recommended to talk to your oncologist or your family doctor to discuss on a case-by-case basis with regards to your breast cancer screening. So next, I want to touch a little bit on our population for women less than 40 years old. Why is this important, you may ask? If we look at the statistics shown, and if we contrast it with the Western population, we then have an inkling why it is so important. In the Asian population, especially in Singapore, we see that 19% of breast cancer in Singapore were aged 44 years and below. And this number is taken from the Singapore Cancer Registry. If we look at the Western population, we see that 40 years and below, the breast cancer population accounts for 4 to 7%. If we contrast it, we see that in Asian, this number is much higher. And we do have a higher proportion of young women with breast cancer. So I think it's very important that we start somewhere, that we educate our young women and make sure that you're aware of your body, you do your breast self-examination on a monthly basis, and at an age appropriate, and you do age appropriate screening as well. So how are the young women with breast cancer, how do they differ from the older women? Generally, the treatment principle is the same, but they do face a lot of psychosocial issues. So for instance, they may be very young, they may be starting their career, or they may have young families. So imagine being saddened with a breast cancer diagnosis. They really have to juggle between work and young family. And they also have to face peer pressures because understandably, their peers are at a different stage of their life. So they can also have issues with sexuality, fertility, relationship. They may also have body image or self-image issues. And all this can complicate their adherence to treatment and their compliance to treatment. Last but not least, they also have to worry about hereditary disease being a real possibility because they are diagnosed at a young age. So for treatment in young women, generally, like what I mentioned just now, the treatment principle really depends on the biology of the cancer, and it really doesn't differ very much in principle, but because in young women, they tend to have a lower index of suspicion. Because if you have a lump in your breast, you may think that you're young and it can't be cancer. So sometimes when cancers in young women are presented, they are usually later on, and they can be larger, they can be more aggressive when diagnosed. So for these women, we generally like to start with systemic treatment first, and we are talking about neoadjuvant chemotherapy, systemic treatment, often even before surgery itself. So another common issues that we have to contend with is fertility issue, because for young women, they may not have completed their family. It may be easier if I describe a case that I've seen before. This is a real case, and it was a patient of mine. So when she was diagnosed, she was only 30 years old, and she had just gotten married a month before her diagnosis of breast cancer. When she presented, her cancer was fairly big. It was at 4 centimeters. We immediately worked her up for chemotherapy. She was sent quickly to see a gynecologist who really tried her best and started IVF protocol. And within 2 weeks, actually, that was really amazing time. She actually managed to do embryo cryopreservation. And I managed to start neoadjuvant chemotherapy in a short span of 2 weeks' time. I think if we talk about, a decade ago, this would have been impossible. But with current modern technology, we are able to initiate chemotherapy without significant delay, even if women desire fertility preservation before starting chemotherapy. So I will continue and come back to this case later on. So why is fertility preservation important? I think it's very important because we want to ensure that survivors have good quality of life. And for early stage breast cancer patients, they are living longer and longer. And, we are talking about stage 1 breast cancer patients with, 90% 5-year survival rate. So they have better survival with better treatment. It's very important that we equip them with the ability to have good quality of life after their diagnosis, so that, after a treatment, breast cancer treatment and diagnosis, they can still pick up their lives and look towards a fulfilling life of getting married and having kids. In short, basically, they have years ahead of them. So when we talk about fertility issues in young women with breast cancer, we really need to establish if family planning is completed. Often they require thorough assessment by gynecologists and obstetricians. And some of the common questions that they commonly ask will be, can I check my fertility level before treatment? How will age affect my fertility? What are my chances of getting pregnant after treatment? And how can I try to preserve fertility? All these are very important questions. The likelihood of start fertility with the chemotherapeutic drug really depends on the type of drugs used, the dose given, the current age of diagnosis, and what was the fertility level before treatment. So we need to consider fertility treatment before the systemic treatment begins. In Singapore, the gold standard is usually embryo cryopreservation. Of course, by Singapore law, embryo cryopreservation can only be done for legally married couples. So the next best option will be egg freezing, which is oocyte cryopreservation. Of course, there are other methods which, we can start straight away without waiting for a 2-3 weeks interval, and that is ovarian tissue preservation or ovarian suppression. So we need to discuss all this in detail before commencing on the systemic treatment for breast cancer, because all these have huge implication in future. Other things that young women really need to know is genetic counseling for hereditary breast cancer. We are not unfamiliar with the Angelina effect. So there is a chance that, when you are diagnosed with a breast cancer at a young age, that there's a real possibility of you being a BRCA1 or 2 mutation carrier. So to understand this and to get genetic counseling is usually a very complicated process, because it's not, I just go ahead and do the testing. You need to have a pre-test counseling, you need to have a post-test counseling, you need to be thoroughly counseled on the implication before deciding on whether or not to go for hereditary breast cancer screening. So this cartoon really depicts, it's not a consult that can be done in one setting. It usually requires multiple consult and a thorough discussion. So coming back to the case. So at the time of surgery, in a very timely fashion, her genetic testing result came back, and she was indeed a BRCA1 carrier. So she actually underwent a prophylactic, removal of bilateral breasts, not unlike what Angelina Jolie went through. And she completed subsequently all her adjuvant treatment, her hormonal therapy for 5 years. And at 35 years old, she told me she wanted to get pregnant. So she actually underwent a successful embryo implantation. This is what I would say a positive example. And after that, we went on to discuss removal of her ovaries to reduce her risk of ovarian cancer. So next, I want to switch gear to breast cancer in pregnant women. So like what our MC had already mentioned, This is not a common phenomenon. Like I want to reassure our those audience with us now is estimated 1 out of 1,000 pregnancy that are complicated by cancers. And when we talk about breast cancer, only 1 in 3,000 women are diagnosed with breast cancer during pregnancy. But one thing is that with more women postponing marriage and childbirth, we do note that this incidence has increased over time. When we talk about treating cancer in pregnancy, understandably, there are multiple challenges. Because really, we are trying to treat the mother who is the beneficiary of the treatment, but we are putting also the fetus at risk. And it's definitely very difficult to avoid some element of compromise. Also, scientifically, we have a lack of randomized data to support the safety and efficacy of standard treatment algorithms. What do I mean that? Basically, when we talk about pregnant women, it's very difficult to carry out, phase 1, 2, even 3 trials, because it's not possible for us to categorize the pregnant lady and say, we categorize you into arm A and arm B, and then arm A received this treatment and arm B received that treatment. Basically, it's not ethically possible to do a trial. So a lot of the data that guide our treatment decision really comes from case studies, observational cohorts, and retrospective analysis, meaning we look back at those patients who were pregnant and who completed the treatment, and we take example from there and treat our patients. And of course, different patients will be different because they are at different stage of their pregnancy, they have a different cancer. So it really requires us to look at the patient on the whole and also individualize our treatment plan to ensure that there's safety for the patient, and at the same time, we minimize the toxicity for her fetus. So really, we are balancing the risk to the fetus and also the risk to the mother, because the mother is the person who is suffering from cancer. And often, we really requires a multidisciplinary team. We need to work closely together with our gynecologists. We even have to work closely together with our neonatologists to ensure that the treatment process is safe throughout. So when we select systemic treatment for breast cancer in pregnancy, we have a few choices. Of course, the most obvious choice is to defer some or all cancer therapies until after delivery, while at the same time, we closely monitor the patient during the pregnancy. However, this is only possible in select cases, because especially only for those cancer when they are detected at the end of the pregnancy, then the wait and the monitoring time is not too long. Most of the time, we do see a lot of patients in the middle of their pregnancy, because the pregnancy is 40 weeks long. A lot of times we are seeing patients in the middle of their pregnancy. So for this patient, it will be very difficult for us to withhold treatment for the cancer and wait until after pregnancy. And we will need to bite the bullet and go in and initiate treatment. Of course, one last option will be to terminate pregnancy. However, I do want to make a point that no data suggests that termination improves survival, although it is offered to select patients with high risk. So this essentially is a summary of our therapeutic approach towards breast cancer in pregnancy. We can and we have given chemotherapy after the first trimester. So we can safely give it in the second trimester and in the third trimester as well. However, we do note the gap there before delivery, because we want to stop the chemotherapy ahead of delivery to ensure that the blood counts and all that normalize for the patients so that the delivery can be safe. Breast surgery as well as lymph node interrogation can be done safely throughout all trimester. And some of the things that we definitely can't do and we have to wait until delivery will be hormonal treatment, as well as some targeted treatment, and also radiotherapy. I think an important question which a lot of people will be interested to know will be, what are the pediatric outcomes after maternal cancer diagnosis? So this is a trial that is done and published by a very reputed scientific journal. Basically, the author actually matched children whose mother were diagnosed with cancer during pregnancy and received treatment with those without a cancer diagnosis. So the children were followed up prospectively and they were compared, in terms of general health, cognitive function, as well as cardiac, which is the heart function. And it was found that they do not differ very much. But I think one important take-home message is that the IQ testing actually improved with each extra week in gestation. So what does it mean for layman term? It really means, and it really tells us that, the mother can have, cancer treatment, can have chemotherapy during pregnancy without affecting the children, as long as the children were carried as much as possible to term, meaning we try to ensure that it's a full-term delivery, even though this may be more difficult, especially when the patients are undergoing chemotherapy. But we can try to do that. So the conclusion for breast cancer diagnosed during pregnancy is that it is uncommon in young women, but it is definitely increasing in frequency. The goals of therapies are to conform as closely as possible to standardized protocols for patients without concomitant pregnancy, meaning we will try as much as possible to use the chemotherapy that we will use for women without a pregnancy for the same type of breast cancer biology. And this will sometimes involve an element of compromise. We can successfully perform surgery and also provide chemotherapy. And really, it requires a multidisciplinary team approach where we have to work together as a team, together with the patient, together with the gynecologist, together with the neonatologist. And also we have to, individualize the treatment, especially for each patient. So with that, I want to also highlight that we have a young women cancer program because we do recognize the unique challenges that young women with cancer face, and even breast cancer in pregnancy, they also fall under this category because the women are young, and when they are young and they have this cancer diagnosis, they may face a lot of unique psychosocial challenges, which older counterparts do not. So with that, stay safe and also stay positive, and thank you very much.
Thank you very much, Dr. Lee, for sharing with us all your case studies and also giving us a better insight about this topic. And I really like the idea of you sharing with us about your hiking trip to the Italian mountains with breathtaking views. Well, I hope all of you, if you have any questions for Dr. Lee, you will be able to address that later on after our next speaker's presentation. Right. I'd like to introduce our next speaker right now. He is Dr. Timothy Lim, and he is a specialist in obstetrics and gynecology. His current practice is at Timothy Lim Clinic for Women and Cancer Surgery at Mount Alvernia Medical Center. Well, he was the head of Department of Gynecological Oncology in KK Hospital before embarking in private practice. He is the current president of the ONG Society of Singapore and the president of the Society for Colposcopy and Cervical Pathology of Singapore. His subspecialty interests are gynecological cancer, fertility sparing cancer surgery, minimally invasive cancer surgery, colposcopy, and treatment for pre invasive cancer. Well, today he will be speaking about management and outcomes of gynecological cancer in pregnancy. So, shall we please welcome Dr. Timothy Lim?
Thank you for the introduction. Let me share my screen. Okay. So I'm going to discuss about the management of gynecological cancers in pregnancy, and in this, I'm going to talk a bit about the general principles of obstetrical and cancer management. And then following which, then I'll talk about the specific cancers in pregnancy which we encounter, mainly ovarian and cervical cancer. And then after that, some concluding slides. Some images in this presentation are graphic, so I hope viewer discretion is advised. Okay, so as mentioned by Dr. Lee earlier on, cancer in pregnancy is indeed uncommon and very complex to manage, and really poses a very serious challenge to everyone involved in the care of the pregnant woman. Which is why it's going to be multidisciplinary. The women cancer is diagnosed in pregnancy. And the most common cancers that we encounter for gynecology is actually cervical and uterine. Well, this slide is one of the latest one, where showing you what is the relative incidence or the different cancers encountered in the pregnancy. And of course, breast cancer is still the most common. But interestingly, cervical cancer is also getting very commonly diagnosed in pregnancy now. It's the second most common, followed by lymphoma and ovarian cancer. This data is actually from the European Union. Okay, so what are the available options for the pregnant woman when she's diagnosed with gynecological cancers? Essentially, the three things. Of course, we can initiate cancer treatment during pregnancy, because as shown by the other one, giving chemo is relatively safe now in pregnancy. Or we can do expectant management. That means we just observe the lady until she delivers, following which then we manage the cancer. And of course, the third option is a termination of pregnancy before the legal limit of 24 weeks. But patient must be aware when she's diagnosed with cancer in pregnancy that this could be actually her last pregnancy. So this will also come into the decision making. So when we manage cancers in pregnancy, we was worried about scans. A lot of patients ask, "How, doctor, what scans can I do? Can I do CT scan, PET scan?" Well, these two scans are generally not recommended because of the risk of ionizing radiation to the baby. Right? Because when we treat the pregnant woman, we don't treat just one patient. Actually, there are two patients who are treating at the same time, mother and the baby. So, which is why MRI scans is the modality of choice for organic cancers in pregnancy, because it's been shown to have manageable risk in pregnancy. Of course, must avoid certain contrastive gadolinium, which is a plus. MRI scan is very important because we can then evaluate the extent of the cancer spread in the lady. Okay, what are the obstetric considerations? Right? So the things for all women with cancer in pregnancy are considered high-risk pregnancy. And of course, if women undergo surgery, right, there's surgical risks, which I'll elaborate on later on. And in women who have cancer in pregnancy, usually we would consider giving them steroids. What are these things? These are actually medication to help the baby's lung to mature, so that baby, when they're born, they don't have breathing difficulties. The reason is because women who are diagnosed with cancer pregnancy, they are at risk of actually delivering before reaching term pregnancy. And this women being high risk, we're also worried about baby's growth. All of them will be scanned regularly, called growth scans, to check, to make sure baby is growing well. And secondly, also to check the blood flow to the baby through the umbilical cord, to make sure the baby is receiving enough nutrients. The reason is because there's risk of growth restriction, right? There's a risk of small baby, even stillbirth in women when chemotherapy. That's why we watch them very carefully at obstetricians. So if we were to do surgery, gynecological surgery in pregnancy, what are the major risks? Because the cancer is actually affecting, right, the organ which is holding the pregnancy. There's a risk of miscarriage, risk of preterm birth. General anesthesia has been also found to be associated with low birth weight babies. And of course, there's also the other usual risks that are encountered due to bleeding, inadvertent injury to surrounding organs, and even infection as well. So we have to be very mindful when we discuss this with the lady who's been diagnosed with cancer. It's also very important to minimize the movement of the gravid uterus, because we cannot press on the uterus too much. Otherwise, there will induce a miscarriage. And how can we perform the surgery? Traditional route is, of course, a laparoscopy. It means making a big cut to remove the cancer. Or nowadays, we can even do it through a keyhole surgery called laparoscopy. So what are the things that we also consider when, as a obstetrician when dealing with gynae cancers in pregnancy? It's the timing. As mentioned by Dr. Lee earlier on, we always aim to deliver as near term as possible to avoid the problems of prematurity. We aim for at least 37 weeks. And the patient is giving chemotherapy, yes, we aim to deliver 3 weeks after, so that the chemotherapy effect on the mother is least. Mode of delivery, of course, we always encourage vaginal birth if possible. But cesarean section has to be performed for obstetrical indications or certain type of cancers, for example, cervical cancer. You have to do a C-section or one diagnosed with this cancer. Analgesia, right? And in pregnancy, of course, epidural is very commonly done. It's okay to have that, but it's contraindicated in some cases where the woman may have brain or bone metastasis, or those with blood disorders. And what about the risk of any cancer on placenta? Well, it's very, very rare. But nevertheless, usually at birth, we will usually send the placenta for analysis as well. Make sure there's nothing there. What about after delivery, breastfeeding? Generally, we always encourage breastfeeding for women who have given birth. Yeah, it's definitely allowed. There's no contraindication. And recent studies show the lack of perceived reduction in breast milk for women exposed to chemo during pregnancy. However, breastfeeding is generally not recommended if she's having chemo because the drugs may be excreted in the milk and may pass on to the baby. The other important thing that often we never think about is, of course, the risk of postnatal depression, right? Especially more so when a woman is diagnosed with cancer during pregnancy. So social support is very, very important. Okay, what about baby outcome, right? So as shown by Dr. earlier on, generally the outcome is quite okay. Contrary to what people have thought about more than 10 years ago, actually in terms of the long-term outcomes, right? The neurocognitive outcomes are similar to non-exposed babies to chemo. And even behavior studies show that actually there's no difference also, which is good. So however, when the baby is born, right, the pediatrician will generally come and assess them for several things. They will relate the baby for any blood disorders, make sure there's no congenital defects, and of course they also check the baby for any heart issues and also hearing as well. All these are all part of the standard checkup that the neonatologist will perform after the birth of the baby. Okay, now we'll go into the cancer proper. 2 cancers which I'll discuss. Cervical cancer, right? First one, cervical cancer. So cervical cancer, although it is the second most common cancer encountered in pregnancy, it is still very rare. It's only 1 per 10,000 pregnancies where it's seen. And what are the most common complications? It is actually vaginal bleeding. So any vaginal bleeding in pregnancy, usually as a gynae, we're a bit worried. So we will always check. Right, we cannot assume it's just due to threatened miscarriage or due to the antepartum hemorrhage due to obstetrical reasons. So we always check the lady, make sure the cervix looks normal, and there's no abnormal growth or anything. The cervix causing the bleeding. Okay. And fortunately, there's no evidence that the pregnancy worsens the outcome of disease and vice versa. If the lady is diagnosed with precancerous cervix, right, usually they have an abnormal pap smear, and the diagnosis is made with a colposcopy and a biopsy, as shown in this picture. That's how it's done. And then we get biopsy that tells us whether it's precancer or cancer. But if we do it during pregnancy, the colposcopy is challenging, right? Because the changes on the cervix, right, may make the cervix look more angry looking. It look like there's some growth there, but it's not. It's actually due to the changes occurring because of pregnancy. And if we were to do a biopsy or any form of surgery on the cervix during pregnancy, there's increased risk of bleeding because the cervix is usually very engorged with blood. But if it's precancer, it's fine. Usually we'll just tell a lady, don't worry, can do a pregnancy and then can give birth normally also. Then after that, we'll reassess after she gives birth or 6 to 2 months later to check the cervix again, and then follow on by treatment if necessary. However, if there's microinvasion, that means it's really early cancer, then of course we would have to do something called cone biopsy, which you see in this second picture. We'll make a circumferential cut around the cervix to remove microinvasive cancer. Microinvasive cancer, you don't see the growth visually with the naked eye. It's only seen on the microscope. So in management of invasive cancer cervix, there are main 4 things that we look at as a gynecologist. It's actually the extent of the local spread of tumor, whether the lymph glands are affected, which trimester of the pregnancy the patient is diagnosed in, and of course the type of cancer. And fertility preservation is only possible only in early cancer usually. So if the patient has early cancer diagnosed in first trimester, no issues. Like I mentioned earlier on, if it's microinvasive, we just have to do a cone biopsy. If it's slightly more advanced than a 1A cancer, then of course we have to discuss about definitive treatment with the patient, which will mean a resultant loss of pregnancy for most women, because we have to remove the entire uterus. In Western countries, they have experimented with a new form of surgery called fertility pancreatiectomy in pregnancy. We try to cure the cancer at the same time, as well as preserving the ongoing pregnancy. This has never been done before in Southeast Asia, and I don't have experience with doing this during pregnancy, but I can show you how it's done in the non-pregnant lady, because that's what we do for our cases. However, Western studies, where it's done, shows that the fetal loss, that means the loss of the pregnancy after the procedure, is 1 in 5. And this like 10 studies with 90 patients over the last 10 years. Okay, so what about advanced cancer? Unfortunately, in advanced cancer, we have to start treatment as soon as possible, especially in such early on pregnancy. So if the radiation therapy will result in the loss of the pregnancy, unfortunately. So I'll just show a bit of what tracheotomy is. Essentially, to remove the cancer, right? This is a picture of the uterus, and the cervix is below the body of the uterus, and then after for the vagina. So of course, in this procedure, we're removing the cancer affecting the cervix and a bit of the vagina and the tissues around it, so that we can get a clean margin around the cancer to effect the cure. So this is what it will look like. Okay. So this is a non-pregnant woman. Okay, this is a case I did 10 years ago. So non-pregnant. So this is a uterus, and then what we do is that we will separate it from the vagina, okay, and then flip the whole uterus up, and then remove the affected portion of the cervix or the vagina. And then after that, we will reconnect the uterus back to the vagina. That's all. It's a relatively simple procedure. Then after that, that's it. So it pulls back into the vagina. So the thing is right, and this is 6 months after the procedure, a new cervix will form. So this is how a tracheotomy is done. So the thing is right. So this is what some specialists in advanced centers overseas are doing for selected patients with early cancers of the cervix diagnosed during pregnancy. Okay, so what happens if the diagnosis is in second trimester? Now we can do something to help preserve the fertility, which is chemotherapy. Right? So neoadjuvant chemotherapy can be given to pregnant women safely during the second trimester. And however, if the lady doesn't want to continue the pregnancy, they can still go for the definitive treatment for early cancers. In third trimester, however, the standard treatment is going to be neoadjuvant chemo, especially if the cancer diagnosed in the early third trimester of pregnancy. Then we will wait until the patient's term, and then after that, get the baby out by cesarean section, and after that, followed by definitive treatment. However, if the lady, which is very uncommon, to be diagnosed with cervical cancer, let's say when she's 34 weeks pregnancy, that's very rare without any symptoms. Then of course, we will have to delay the treatment till she delivers at 37 weeks. Because 3 weeks will not make any difference. So what do we do as obstetricians, right? I say aim for 37 weeks if possible. But at 34 weeks, usually I give my patients steroid injection, lung maturity. And then after which, then we do a C-section. The only exception is if the patient has had what we call a cone biopsy done for microinvasive cancer, then it's fine. Because the cervix will have healed by the time she reaches term, then she can give birth normally. Otherwise, it's going to be a C-section for the patients. At C-section, we can also do the definitive surgery at the same time. That means after I get the baby out by C-section, close up the womb, then it's either remove the entire uterus, or we can perform then the trachelectomy, which you saw earlier on in those pictures during the time of C-section. But this is only for the cancers. If the patient has advanced cancer, locally advanced cancers, then of course during C-section, we will do something called surgical staging, where we would then remove some of the lymph lines to find out whether are they involved by cancer or not, and then after which the patient will then proceed with chemoradiotherapy about 4 to 6 weeks after C-section. Okay, next one will be ovarian cyst in pregnancy. This one is a bit more common because ovarian cyst is every time we do scans as a gynecologist or ladies pregnant, sometimes we see cysts, right? It's very common. 2 to 5% of all pregnancies we will pick up an ovarian cyst. But whether this cyst is sinister or not, then of course, fortunately, majority are benign, of course. And large cysts, right, beyond 5 centimeters is actually very, very uncommon. Most of the time, it's small ones, like 2, 3 cm type. So malignant masses, that means malignant ovarian cancer, is extremely rare. 1 in 15,000 to be born pregnancy. So what do we do like ultrasound? Right, ultrasound black and white. Then we see this growth when we do a scan. Right? So this is a borderline tumor, right? Borderline ovarian tumor. There's no malignant potential, right? And this we see sometimes during pregnancy. And the serous type is most common, and usually generally it's very good prognosis. And usually this one, we don't have to remove the uterus one. We just have to remove the affected ovary, and the baby is fine. Malignant cysts on ultrasound will look more sinister looking. They have a lot of this solid growths inside the cyst, as seen in this ultrasound images. So if we encounter ovarian cancer in pregnancy, right, what can we do to help salvage the pregnancy? So if it's early, and fortunately, right, if we do encounter ovarian cancer in pregnancy, usually it's early. Right? And what can we do? Usually, we would have to remove the affected ovary for diagnosis. So we need to do surgery, and usually it's done in the second trimester. And we will remove the ovary for diagnosis, and then we may have to do staging at the same time, which involves removal of the bed apron, large called omentum, and some lymph glands. Then after which, then chemotherapy may be needed depending on the stage of the cancer. However, sometimes the patient is diagnosed only after cyst removal. We've had a few cases of that, where the patient had the cystectomy done by a generalist and then found to have cancer. So what do we do? So these patients probably will need the chemotherapy, after which then we perform the definitive surgery after the delivery of baby. And usually it's a cesarean section, but we can at the same time do the definitive operation. If the patient is advanced cancer, which is rarely encountered, I only seen one case of advanced cancer in pregnancy 5 years ago. Right, this is a very uncommon situation to encounter. So in this situation, right, it happens in the second or third trimester. If it happens in the first or second trimester, it's very dicey now. What do we do? Do we do surgery first? Do we give chemotherapy or what? So in general, the principle is that if the diagnosis is less than 20 weeks, it's better to go in and clear all the cancer, and then after that give the chemo. Because chances are, if we don't do anything, the patient will succumb to the cancer. We'll lose both life. However, fortunately, we can also discuss about using chemotherapy after getting diagnosis, of course, followed by the actual surgery remove all the tumor after the delivery. We attempted the second one for the one patient that we encountered, but she was diagnosed in the what we call late second trimester. It means about 24 weeks. And then after which chemotherapy was given, and then we did C-section for her at 37 weeks. The thing is, right, however, her cancer is really advanced because when she was diagnosed, she had a lot of tumor within the abdominal cavity, tumor deposits. So unfortunately, although her baby survived, but she succumbed to the cancer about 1 month post. Fortunately, the baby is fine. It's now 5 years old. So the thing is, right, we still try our best to aim to deliver women diagnosed with cancer as near term as possible. And for ovarian cancer, if they have had the treatment during the pregnancy, they can opt for vaginal birth. Okay, just a bit about the chemotherapy in pregnancy. Generally, it is safe and given in the second trimester, or must avoid it in the first trimester because of the risk of congenital malformations, 25%. And we always aim to deliver the baby 3 weeks after the last dose. Okay. Let's talk about the two other categories of ovarian tumors. This is the other category that we encounter, called borderline tumors. So these are tumors of so-called low malignant potential, but they are nowadays regarded as precursors for low-grade ovarian cancers. And usually, again, they are diagnosed in early stage, very, very good prognosis. And the surgery for this sort of cancers is almost always fertility sparing, which means to say that after removal of tumor, patient can still want to have future pregnancies. There's another category called non-epithelial tumors in pregnancy, and these are what we call germ cell tumors, sexual stromal cell tumors. And again, usually they're diagnosed in early stages, and fertility sparing is usually the thing to do for women who are diagnosed with this cancer during pregnancy. So no issues as well. So generally, the outcome when a woman is diagnosed with ovarian cancer in pregnancy is good. There's no evidence that pregnancy itself alters the survival outcomes in patients with ovarian cancer. And in this recent review of the obstetric outcome for 105 women diagnosed with ovarian cancer, very good live birth rates, although a lot of them deliver C-section, but the outcome of the babies are good. There's no difference in the growth of the baby, and there's no increase in fetal malformation for the baby who have been exposed to the baby. However, they do find that yes, there is a risk for infection related, of course, to surgery. So in conclusion, so management of gynae cancers in pregnancy is actually very complex because we're dealing with the organ that's holding the baby. So definitely require multidisciplinary effort as shown in this diagram here, where you see the pregnant woman is at the center of everything, where of all the help that she needs from the medical oncologist to the gynecologist, pediatrician, obstetrician, midwives, nurses, and so many people who are involved in the care of these women. But with proper management, the oncology and obstetrical outcome can actually be very favorable. And even the pediatric outcomes as well. Being exposed to prenatal chemotherapy actually appears to be reassuring. Thank you.
Thank you so much, Dr. Lim, for sharing with us. Well, with that, I would like to thank our doctors, Dr. Lee and Dr. Lim, for their informative presentations. Well, we have actually come to the Q&A, questions and answers segment. So please feel free to raise any questions just by typing in the questions in the comments box. And our doctors will be able to address these questions and answer them, okay? I think we have a few questions right here, which I would like to pose to our doctors, Dr. Lee and Dr. Lim. All right, so we'd like to say a big thank you to those of you who are watching us, our ladies and gentlemen, who have actually been attentive and also to pick up some questions that you might want to ask. So the first questions that one of our viewers have asked is, hold on a second. All right, let me just take a look. All right, this question is, what treatment options for breast cancer are available to me when I am pregnant? And what is the most common gynecological cancer during pregnancy?
Okay.
Can I have?
So maybe I can take the first question.
Okay.
So what treatment are available? So I think I've gone through that briefly, but I'd like to reiterate on that.
Right.
So when a woman with breast cancer during pregnancy, they may feel very lost and they may think that, they can't get any treatment. But the truth is that, there are treatment options available. I think it's very important first that you seek medical consult. And then for breast cancer treatment, it really depends on the biology of the breast cancer. For instance, we often talk in terms of, what is the breast cancer subtype? Is it hormone sensitive? Is it HER2 positive, etc.? So we can definitely start chemotherapy treatment after the first trimester, because the first trimester, that's when the organ genesis is happening. That's when the organ formation of the fetus is happening. So we try to avoid that. So we can always give chemotherapy after the first trimester.
Okay.
For surgery, I think maybe Dr. Timothy can go into that further. It is possible to do surgery even during the first trimester. There are a lot of actually studies, case series that showed safety even during the first trimester all the way to second, third trimester. So there are definitely a lot of treatment options available. I think the main thing is to get in touch with your oncologist so that you can be treated in the best way, depending on the biology and the subtype of your breast cancer.
Okay. Right. Thank you so much, Dr. Lee. Dr. Lim, would you like to add anything?
No.
Okay.
That's all for this question.
Okay. All right. Next question is, will breast cancer affect my newborn?
Okay, so I think this is definitely on the mind of a lot of women, a lot of mothers. So I think the reassuring data that we have out there, as illustrated by one of the major study that I highlighted, because that was highlighted, that was a study result of a very reputed journal article that, in the scientific community. So when the children were compared between women with breast cancer treated during their pregnancy versus those without, it seems like, the children do as well in terms of cognitive function, meaning the brain functioning, the general health, and also the heart function. But we have to be very careful, and we have to, treat the patient as well as possible, in the sense that we try to delay the pregnancy to as term as possible, so that, every week closer to term will make a difference. So as long as the children are delivered as close to term as possible, the effect is actually not significant.
I see. Thank you so much for answering this question. And also, I'd like to say a thank you to all our viewers because our questions are coming in, and that's good. So keep your questions coming in because we have ample time to address your questions. Well, coming to our next question right now is well, during pregnancy, I could feel lump on my breast. Does it mean it's cancer?
Mm. So that is not 100%, of course, but however, if you feel a lump that is new and that wasn't there before, I think it is definitely prudent and safe to get it checked out. So see a doctor, see a family physician, or make an appointment with even an oncologist if you find that you are worried about it, or if the lump is new. If it because sometimes when women are breastfeeding, it is also common that you get lactation ducts blockage, and that is a common problem. But we cannot assume that all lumps are due to a benign condition. If there is a new lump, I think it is just safe to get it checked out by a doctor.
Okay,
Mm.
right. Okay, this question I think is very common because I think all parents would be very concerned is, can I pass my cancer to my baby if I found out I have cancer when I am pregnant?
The short answer is no.
Okay, that's good news. Yes. All right. Okay, there's quite a number of questions coming in, so I'm going to quickly move into the next one. Okay, this question is directed to you again, Dr. Lee. Does pregnancy speed up breast cancer?
Okay, so it really depends on the subset of breast cancer per se, whether it's hormone positive or hormone negative. So when we talk about breast cancer during pregnancy, actually we are, talking about very technical realm already, because when we talk about breast cancer in pregnancy, we can actually segregate it more in depth into two types of cancer. One is breast cancer diagnosed during the pregnancy, and also one is the breast cancer diagnosed in the postpartum period. What we
Okay.
are knowing from research results is that cancer diagnosed in the postpartum period, it usually is due to the breast involution, and also is due to the condition that's happening in the breast, coupled with the hormonal milieu in the body, and that usually heralds a poorer prognosis versus cancer diagnosed during the pregnancy, because for the cancer diagnosed in the pregnancy, they may even already be there before the pregnancy happens, you see. So actually, technically, there are some differences. But what we are learning, we are continually learning more about this, because it is a relatively an area where it has been less studied because of the small number. But with more and more research, we are finding out more that in the postpartum period versus during the pregnant period, they may even be different types because of different biology, and they have different prognosis.
Okay. Right. Thank you so much. Which birth method would you recommend if I am diagnosed with cervical cancer?
Thanks for the question. So for patients with diagnosed with cervical cancer, right, in general, most women would deliver via cesarean section. The reason is because if the ladies are going to labor with a tumor on the cervix, two things can happen. One is hemorrhage, can bleed a lot before the baby comes out. And secondly, even if let's say do successfully deliver vaginally, the tumor can implant itself on the vagina. Because usually when we do vaginal birth, we have to make a cut and called an episiotomy in order to facilitate the delivery of the baby. And the tumors can implant onto the site where we need the cut, which is reason why we don't recommend vaginal birth for patients with cervical cancer. The only exception is unless the cancer has been treated beforehand. That means that in the first trimester, we find there's a early cancer on the cervix, or we have done cone biopsy, where we remove higher microinvasive cancer. There will be time for the cervix to heal properly. It takes about 2 months for the cervix to heal sufficiently enough. Then the patient can, of course, deliver normally. generally without any issues.
Okay. Right. Well, we'd like to say a big thank you once again to all the viewers for giving us all the attention and also giving us the questions that we have addressed over the Q&A segment. So we'd like to wrap up the Q&A segment right now. Once again, thank you so much for our doctors to come in to join us on a Saturday afternoon like this and being able to share a deeper insights about the topic. Well, we'd like to say on behalf of Mount Alvernia Hospital, a big thank you to all of you for spending your Saturday with us. There will be more interesting and informative session coming up to address different topics. So do please, if you can, like our Facebook page, Mount Alvernia Hospital, so that you will be in tune of what's happening and what are the virtual events that are coming up for you. And please don't forget to like and share this program that we had, and maybe some of your friends might also want to watch on this topic about cancer during pregnancy. So we'd like to say goodbye to everyone. Is there anything else that Dr. Lee and Dr. Lim would like to say to the audience here? Okay.
Thank you for tuning in.
Yeah.
Thank you.
All right. So thank you so much and have a lovely weekend ahead. Goodbye.